Hi, I'm Dr. Eric Forman, and I'm the Medical and Laboratory Director at Columbia University Fertility Center in New York. In this video, I'm going to be discussing using preimplantation genetic testing for aneuploidy, PGT-A, to enhance selection for elective single embryo transfer. It is well known that having the wrong number of chromosomes, or aneuploidy, is a leading cause of infertility and failed pregnancies, and one of the main reasons that embryos that appear morphologically normal often do not implant when transferred to a woman's uterus after assisted reproductive technology. This increased prevalence of aneuploidy also explains much of the decline in IVF success rates with increasing maternal age when using a woman's own eggs. This phenomenon of aneuploidy increases significantly as women age, as demonstrated by the incidence of trisomy in clinically recognized pregnancies, and the incidence of aneuploidy when embryos are tested using preimplantation genetic testing technology. To overcome this high aneuploidy rate with increasing maternal age, it became standard practice to transfer more than one embryo during IVF. However, this resulted in an excessively high risk of twin and even higher order multiple pregnancies, which carry increased obstetrical and neonatal risks. The idea of performing elective single embryo transfer has long been advocated. However, studies demonstrated significantly lower chance at live birth when a single embryo transfer was performed as compared to multiple embryo transfer. Although PGT-A was originally developed to improve outcomes for those with the poorest prognoses in IVF, such as women with recurrent implantation failure after IVF, women of advanced reproductive age, or those with recurrent miscarriages, this technology could also be applied to enhance selection for elective single embryo transfer. When considering PGT-A to select a single normal embryo for transfer, one must obtain a sample or biopsy from an embryo and analyze that biopsy. The biopsy must not be harmful, or that may reduce the embryo's ability to successfully implant. The analysis of the DNA from the biopsy must also be an accurate reflection of the true state of the embryo. That is, if the result is normal, the embryo should have an improved chance of progressing to a healthy baby. And if the result is abnormal, that embryo should have a very low to no chance of producing a healthy live birth. The earliest version of PGT-A failed on both of these measures. Day 3 biopsy was performed to remove a single blastomere, or cell, from a Day 3 embryo. This type of biopsy was later shown to be detrimental to that embryo's reproductive potential. Furthermore, the technology of fluorescence in situ hybridization, or FISH, was not properly validated to be performed on single blastomeres and accurately predict the state of the embryo. The technique of Trophectoderm biopsy, in which 5 to 8 cells are gently removed from the outer layer of a Day 5 or 6 Blastocyst embryo, was shown to be safer and more accurate than Day 3 biopsy. Using more robust technologies such as single nucleotide polymorphism or SNP arrays, array comparative genomic hybridization or array CGH, quantitative polymerase chain reaction or qPCR, and most recently next generation sequencing, NGS technologies, the DNA in the biopsied cells could be amplified and analyzed to make copy number predictions for each chromosome, the 22 numbered autosomes, and X and Y, the sex chromosomes. These technologies were validated in different ways, including comparing to the karyotype of known cell lines, as well as performing non-selection studies, during which the PGT-A result was not revealed until after the embryos were transferred. While not perfect, the normal embryos have a higher rate of successful implantation, while abnormal embryos have a very low, but not zero, rate of implanting successfully. Armed with this evidence, a clinical trial was launched using the PCR technology to compare the outcomes from the transfer of a single euploid embryo versus 2 embryos that were not biopsied or tested. 175 patients who were candidates for elective single embryo transfer were randomized at the point where they had at least 2 transferable blastocysts to choose from. In the treatment arm, all embryos underwent trophectoderm biopsy, and a single normal embryo was chosen for transfer after analysis of the DNA using real-time PCR. In the control arm, 2 blastocysts were selected for transfer based on their appearance under the microscope. Of note, at the time the study was being performed, double embryo transfer was the most common practice, and elective single embryo transfer was rarely performed in the United States. Patients in both treatment groups had excellent delivery rates, over 60% of randomized patients delivered after their first embryo transfer. However, in the PGT-A group, all deliveries were singletons, whereas in the control group, nearly half were twins. As expected, obstetrical outcomes such as preterm delivery, length of stay in the neonatal intensive care unit, and risk of low birth weight were all significantly higher in the untested double embryo transfer group. Other non-randomized trials have also shown that euploid elective single embryo transfer can maintain excellent delivery rates through age 42. Other randomized trials have similarly shown that PGT-A technology can be used to enhance selection of embryos for transfer. In light of the findings of this trial and others, the Practice Committee of the American Society for Reproductive Medicine now recommends that elective single embryo transfer be performed regardless of age when transferring a chromosomally normal or euploid embryo as determined with PGT-A technology. The ART field has shifted dramatically, and we are finally witnessing the long-desired dramatic increase in the acceptance of elective single embryo transfer among clinicians and patients alike. Questions still remain regarding the application of PGT-A to clinical ART. Randomized trials showing the benefit of next-generation sequencing technology, which has rapidly become the most common method of performing PGT-A, are needed. In addition, the impact of predicted mosaicism or subchromosomal rearrangements needs to be clarified, as these diagnoses were not reported on embryos in the trials listed above. Nevertheless, the evidence is clear that in patients who produce good quality embryos, Trophectoderm biopsy and PGT-A is a reliable method to safely select a single normal embryo for transfer. This approach of euploid elective single embryo transfer maintains excellent outcomes while virtually eliminating twin pregnancies which have higher obstetrical risks. Thank you for watching this video on PGT-A and elective single embryo transfer.